So today we're going to talk about the serious problem of hypoglycemia. We're going to talk about standards of care for addressing severe hyperglycemia. We're going to recognize the current challenges related to glucagon administration and severe hypoglycemic events. And we're going to talk about an action plan addressing severe hypoglycemia. Now, some of you may recognize this patient. I mean, not him, but you probably have all seen a patient just like this. This is Tim. He and his wife Mia are avid cyclists. They stay really busy with 2 young kids who often come along. He's 31 with type 1 diabetes. He's on 38 units a day, basal bolus. He uses CGM. His average glucose is 123, standard deviation of 40, and his A1C is 6.1. You guys have all seen this patient, haven't you? Maybe not 6.1. That's pretty good A1C, right? So one day while out riding with the family, taking the kids along, he notices his blood sugar starting to drop. So he eats the snacks that he had brought with him, but his blood sugar continues to drop rapidly. Now it's down to 55. He eats all the rest of the snacks and the candy that he had with him, and his wife gets pretty scared and rides off to find a store. Now you're thinking, you got your phone, why didn't you call 911? Because as luck would have it, they're in an area with no cell phone coverage. Now it's getting kind of scary. She returns to find him by a tree, shaky, sweaty, and confused. Blood glucose is 33. The kids are scared, so she helps him to sit down as he becomes quite dizzy and starts to stumble. This would be kind of a panicky situation, wouldn't it? So she encourages to eat all the stuff she brought, and an hour and 2 bags of Skittles later, his blood sugar's finally starting to go up. So what would you counsel Tim to do next time? What do you think is the problem here? Well, there's all kinds of things. He could have done a temporary rate basal reduction, carry more glucose type things, and they could have carried glucagon. Because hypoglycemia can progress to severe hypoglycemia and life-threatening complications rather quickly. So we know that the normal range of blood sugar is about 80 to 130, and we consider under 70 to be hypoglycemia, although I certainly have a lot of patients who consider anything under 120 to be dangerously low. We know the autonomic symptoms are shaking, chest pounding, sweaty, hunger. And what we call level 1 hypoglycemia, we call clinically significant hypoglycemia, is anything under 54. That's where they start having neuroglycopenic symptoms, dizziness, confusion, blurred vision, maybe seizure, or loss of consciousness. So that's a pretty scary. Severe hypoglycemia is characterized by an altered mental state, and they require assistance from another person. It's not defined by numbers, but by individual symptoms, and that can vary. So you've all had that patient who said, I was fine, my blood sugar was 30, but I was still good. Yeah, I doubt it, but you know, everybody's different. So it's unpredictable and can be influenced by a lot of factors, including management-related factors, like individuals taking insulin or secretagogues are at risk of hypoglycemia. So these could be too aggressive control. inadequate glycemic control or adherence. Glycemic variability puts you at higher risk for hypoglycemia. Pump or injection errors, we call it operator error. History of stacking insulin doses and bolusing without testing. We don't have anybody that would do that, right? So there's lifestyle and individual factors that can also impact the frequency and severity of hypoglycemia, such as lifestyle behavioral factors, high intensity activity, skip meals, erratic schedule, alcohol use. That's always shocking to people to realize that alcohol actually results in a lower blood sugar initially. And individual factors like poor cognitive status, psychological disorders, increased insulin sensitivity, history of severe hypoglycemia predicts future severe hypoglycemia. Hypoglycemia unawareness, duration of diabetes, and comorbidities such as renal disease. Another one that always comes to my mind also is gastroparesis. So let's talk about severe hypoglycemia and how we could deal with that. Most people with type 1 diabetes experience hypoglycemia. 30 to 40% of people with type 1 will have severe hypoglycemic events, as many as 1 to 3 a year. Were y'all aware of that? That's pretty severe, huh? 50% of type 2 diabetes people experience hypoglycemia, and 1 in 5 of those people will have more than one severe hypoglycemic event per year. Did you know it was that big? A lot of people think that people with type 2 don't have hypoglycemia, let alone severe hypoglycemia. More severe episodes occur in type 2 diabetes because there's 20 times more people with type 2 than type 1. Severe hypoglycemia persists among people with type 1 despite improvements in technology. So we would love to think that the improved pumps and sensors have done away with hypoglycemia. But in people reporting more than one severe event in the last 3 months, look at this. Pump users, about 5%, MDI, 9%. So it's helped, hasn't gotten rid of it. Same with CGM. Non-users, 7%, CGM users, 4.5%. So they help, but they don't eliminate severe hypoglycemia events. 6% of people reported more than one severe event in the last 3 months. Now you think about your patients with type 1 diabetes. Does that statistic ring true? And if it doesn't seem like your patients have that much, it may just be that they're not telling you. It can occur in all levels of glycemic control. This is people with type 1 diabetes experiencing more than one severe hypoglycemic event in the prior 3 months, based on age and recent A1C. This is always surprising to me, and it's going to help you change your practice. So you see the people with less than 7, and you would think that their risk of hypoglycemia would be way higher than the people with a high A1C over 9. And that's just not the case. You have to resist that temptation for that patient with an A1C of 6.8 and they're having severe lows. And you really, your inclination is say, well, you need to raise your A1C, right? Do you think that would help? Not really. Now, in the over 50, I'm going to resist calling them elderly. They do have a higher risk of hypoglycemia. Now, these are people with type 1, so that may reflect more years with type 1 diabetes. Let's look at type 2 diabetes. 11% of people with type 2 reported more than one severe event per year. Look at this. Oh, sorry. So here you can see A1C and the percent of patients with severe hypoglycemia. So you can see there's really not a lot of difference between the 6 and the 9. And people with an A1C over 9, you'd think there'd be less hypoglycemia. It's actually higher. So the next time you're thinking, I need to get their A1C up higher, not going to help, is it? So severe hypoglycemia imposes a substantial burden on people with diabetes, the community, and the healthcare system. So let's look at this. For the patient, it can be debilitating and distressing. 70% of people with type 1, 50% of people with type 2 reported diabetes distress as indicated by the AADE19 test with a score greater than 40. The fear of severe hypoglycemic events can limit therapeutic success. I remember years and years ago, a nurse who was working for me, really cute, young, came to work for me on an inpatient unit right out of nursing school. And she'd had type 1 diabetes since she was like 14, and I was opening a diabetes unit, so she was really excited to work there. I was not real excited when she told me her A1C was 12. I don't know how she got through nursing school. And I kept saying, you need an insulin pump. No, I'm fine. And after she'd worked for us for about 6 months, one day her mother called. I can't get her to wake up. She's just laughing and laughing. I said, you raised this kid. Call 911, we'll stay on the phone. Anyway, she was fine. 3 or 4 hours later, she comes to work. She says, Virginia, I need a pump. I said, what do you think happened? She said, I don't know, but I'll tell you what, I'll never be the same. Waking up on the floor, spread eagle, naked, with these 3 really cute young firemen standing over me, and my mother standing there going, maybe I just need to move up here and move in with you. She's like, I can't have that. Oh, that was my favorite hypoglycemia story. She's still doing fine wearing pumps. Because fear of hypoglycemia can deter optimal control. You all have those patients. They don't want to get in good control. They'll quit. They'll avoid taking insulin for a meal because they're afraid of getting low. They are intentionally not adhering to the insulin program you've suggested. It can cause delays in initiating insulin therapy in people with type 2 diabetes. And among family and friends, severe hypoglycemia can actually be more distressing to the family. 65% of caregivers versus 40% of people with diabetes in a survey reported concern about future hypoglycemia. We've all had that patient come in with their spouse and the spouse hasn't slept in months. They lay awake all night trying to detect when their partner goes low. 90% of caregivers in a separate survey had never given glucagon And the complexity of kits can be intimidated for untrained patients. I'll never forget, years ago, I had the young man with type 1 who was having some hypoglycemia unawareness, and I made sure they had a kit, and I'd showed his wife, and 6 months later, they come in and he tells me that he had a severe event. They had to call the ambulance. And I said, why didn't you use the glucagon? Which is a very unthinking thing to say, as she burst into tears because she panicked. She couldn't remember how to do it. And I should have not been so, I don't do that anymore. I felt so bad for them. So it's one thing to be taught one time, because for us who handle syringes and dialing up and everything, it's no big deal. For the person who's not used to giving insulin or giving injections, it's pretty overwhelming. Education is critical for the caretakers who are helping manage that person's diabetes. When we look at community, school, and workplace, what we see is non-severe hypoglycemia can impede productivity and at work and school. So following a non-severe hypoglycemic event, 1 in 5 working adults reported missing 10 hours on average per event occurring at work. 1 in 4 working adults with type 1 or type 2 reported missing a meeting, appointment, or a project deadline. 200,000 people, over less than 20 in the United States, may be at risk of hypoglycemia events during school. So for the healthcare system, it's costly. Annually, severe hypoglycemia events in the United States resulted in 245,000 visits to the emergency room, $1.8 billion with a B in direct costs related to emergency care, inpatient, and ambulatory care. So it's a very expensive proposition. So let's talk about treatment. The guidelines advocate for the assessment and management of risk for hypoglycemia and severe hypoglycemia in all individuals at risk. And here's the ADA and International Hypoglycemia Study Group, and they suggest everybody should be assessed. Patients and caregivers should be educated on prevention and treatment of hypoglycemia, and glucagon should be prescribed for all individuals at increased risk of level 2 hypoglycemia. That's if they're having blood glucoses at the 50-54 level, we should be available should it be needed. And yet, despite recommendations by the ADA standards of care, glucagon remains underprescribed and underutilized. Many people who would be clinically appropriate never have it available. Look at this. All insulin-treated people are at risk for severe hypoglycemia. That's 4.3 million people with type 2, 1.3 million with type 1, and yet 0.66 million people actually fill prescriptions. We've all had that patient, you ask them, have you had your glucagon prescription filled? I'll never forget this. One guy takes out his billfold and pulls out the prescription folded and tattered and 2-year-old prescription. I said, are you going to eat that if you get low? But rather than shame that patient, let me tell you, yesterday I was in a meeting and there were around 50 people in the room. And the facilitator said, how many of you all are insulin-treated diabetics? He said diabetics, I did not say that. And about 15 people raised their hand. How many of you have glucagon with you right now? 0. These are all diabetes educators. Do as we say, not as we do. So we are not innocent. 5% of prescriptions are filled following an emergency room visit for severe hypoglycemia. Yeah, now you fill it. Something about the closing the barn door after. So the absence of a threshold for glucose levels associated with level 3 can challenge the use of glucagon. I'll bet you have all had a patient say, well, I've never had one. Like that's going to protect them in the future. So we tell people if you're conscious, treat with 15 to 20 grams of carbohydrate, glucose, weight 15, check your blood sugar, repeat if it shows continued hypoglycemia, and once your blood glucose returns to normal, have a meal or a snack. For severe, glucagon is appropriate. So we're going to ask some questions. You got your little clicker right there. So which patients are you likely to discuss hypoglycemia management with? So select all that apply. Let's see what we picked. Look at that. So I'm glad to see that very few of you picked number 5. So you said type 1s, yes. Type 2s, people on insulin, pediatrics, that's good. Okay, next. So how frequently do you talk about hypoglycemia? Are you done? She's done. Every visit, good choice. It varies. People who can't make a decision. So my granddaughter used, it matters. Okay. Let's look at the next one. How do you guide somebody, how do you guide someone on when glucagon should be used? So how do you guide them as to when glucagon should be used? Select all that apply. So people who've tried carbs and they're not getting better, combative, feels or looks like they may pass out, they're unconscious, and they're having a seizure. Okay, good. So some people wouldn't use it if the person's having a seizure. Yeah, they need it. So what reasons do you hear from patients? What do they tell you about not having or not needing glucagon? Why did they not need glucagon? I didn't use my last one, so I don't think I need a new one. It's too complicated. CGM will help me know when I'm getting low. I have type 2, so I'm not at risk for severe. My prior healthcare provider never discussed it, and it's too costly. What reasons do you hear? Select all that apply. Okay. Yeah, we hear a lot of that. I didn't need it. So, too complicated. That's probably true for a lot of people. CGM is going to save me. Type 2s don't ever get low. I had one guy with type 2 diabetes and his A1C was 14. And he and I decided that hypoglycemia would be cause for celebration. Okay, thank you for your answers. Okay, so partnering with patients, we're going to talk about what we need to do. First of all, we've got to assess the risk. Find those people who are at high risk, recent history of severe hypoglycemia, and we've got to talk to them every visit. We've got to assess every visit. If you don't ask, they may not tell you. And they may not tell you anyway, but for sure, we've got to ask. We've got to look at their recent history, track the trends in their blood glucose values. You know, one of those clues, I know you all see this, where the blood sugar has gotten a little bit low, and the next one is like 300, because they felt hypoglycemic and ate their way out. And look at risk factors. So we've talked about a lot of these: aggressive control, administration errors, cognitive issues, and behavioral issues. And then we've got to educate people on the prevention and treatment of hypoglycemia. Exercise is a tough one, right? Thank you. Meal schedule changes, like skipping lunch at night, or night shift workers. Those are, or people are adjusting their doses. What could minimize the risk? Looking at insulin secretagogue doses and carbohydrates, using insulin adjustment for exercise. And how should it be treated? Carbs for mild to moderate hypoglycemia, making sure people are carrying glucose tablets if they're out running around, glucagon for severe hypoglycemia, and knowing how to use it. And then we've got to discuss the potential of incorporating glucagon into your patient's diabetes care plans. Who might administer it? How could they be trained? And where might it be needed? School, home, gym, purse, or desk. Out of the 15 or so people who raised their hand in that meeting yesterday, I think almost all of them were women. And we had purses with us. And yet, most of our patients, when they get a glucagon prescription, they put it in the little butter container in their fridge. They never carry it with them. They don't carry it on vacation where things are likely to be high risk. So that's something to really work on. And then prescribe. So remember Tim? So he's concerned because he's already doing everything right. So how can we have him be more prepared to manage future hyperglycemic events? So that's for us to work with Tim and his family, carry better carbohydrate choices for hypoglycemia. We all have that patient who eats a Snickers bar. And I'm like, well, we all love to eat a Snickers bar now and then. I had one guy tell me once, he said, I just live for hypoglycemia. But it's not that great for raising your blood sugar. I had one guy, that still, how can we kill this old wives' tale about that peanut butter sandwich? I said, that doesn't raise your blood sugar. Well, I thought that's what you're supposed to have. No. So, simple, liquid sugars best, glucose tabs, and have glucagon available. And so I try to make sure my patients who are subject to severe hypoglycemia that they have more than one. Yeah, one for the fridge at home, one at work, one to carry in the backpack or purse, right? It's tough. Sometimes you have to fight with the insurance companies. Well, thank you all so much for coming today. Thanks to Xeris